Hi, Dr. Rosen. I am so grateful to have the time with you this afternoon. I am excited to ask you a lot of questions that I know many of us breast cancer survivors have. I'd like to know, what is the most difficult question that you get from your patients? Two of the most difficult questions.
Well, I can tell you the most difficult questions are, is my cancer gone? And is my cancer coming back? And those are always the most difficult questions because we're chasing a ghost. Surgeons, we live in a macroscopic world. We get a mammogram, we get an ultrasound, we see a tumor, we remove the tumor. The pathologists will tell us if our margins are clear. And people, family members, or patients will ask us, did you get it all?
Mm.
And that's easy because did we remove what we saw? And the answer is yes. But the more difficult question to answer is my cancer gone? Because what makes every cancer evil is the ability of cancer cells to break away from the organ of origin and take up residence elsewhere in the body. So as a breast cancer surgeon, that's very easy. I can remove the cancer in the breast, but did cancer cells leave the breast and take up residence elsewhere before I ever met that person? And if that did occur, how am I going to identify it? Well, we have indirect measures of whether there's cancer elsewhere. What's the best indirect measure? Looking at lymph nodes. So when we do cancer surgery, we usually remove lymph nodes. And if cancer is in the lymph nodes, it doesn't mean it's incurable, but it means that you need to treat the whole body because what's going on in the lymph nodes is going on everywhere else in the body. Now, what if there's no cancer in the lymph nodes? Stage 1 disease. There are still some people who have cancer cells that are elsewhere in the body because cancer sometimes spreads through the bloodstream, through the circulatory system. So when someone asks me, is the cancer gone? The honest answer is, I hope so, but I don't know. And that's really the challenge of the medical oncologist, is to understand who might be at greatest risk for cancer cells being elsewhere. And if they are elsewhere, what's the recipe to kill them? Now, we have a new test that can potentially help us a great deal when it comes to knowing who we should treat and who we shouldn't treat. And that's called circulating tumor DNA testing. So what we know about many cancers, including breast cancer, is that cancer cells will end up with some of those cancer cells in our bloodstream. Well, we have a test right now that can take a piece of your cancer and look for its unique signature. And then we look in the bloodstream and we see, is there any DNA from your cancer currently in your bloodstream right now? And it's a dynamic test. It's like taking a picture in time because we can do that blood test. It's just a blood draw. So we can do that blood test when you're diagnosed before you're treated. And let's say it comes back positive. Well, we can then repeat that blood draw after surgery. Did it go to zero? If it didn't go to zero, then we know that you have residual cancer left behind. We have a fancier term for that. We call that MRD, minimal residual disease, or molecular residual disease. What we're basically saying is we've cleared the cancer macroscopically, but microscopically we haven't. Now, what's very exciting about this blood test is this gives us a way to measure our success. And this, I believe, will really revolutionize the way we treat cancer. Because right now, we treat everyone not the same, but we treat people by categories. And if you have a HER2 amplified tumor, you're going to get a certain recipe. And that recipe is going to continue until the prescribed end. Well, what if this test gives us information to say that maybe you don't need all that chemotherapy. Maybe if you just get some of the chemotherapy and you have no evidence of cancer in your circulatory system, maybe we can de-escalate. Maybe we can give less chemotherapy. We're not there yet. We're compiling data. We don't know if this is going to work that way, but I'm very optimistic that we will be able to de-escalate treatment for some women who clear their ctDNA early in the course of their chemotherapy. The converse is true. What if we treat someone and there's still ctDNA from their cancer in their bloodstream after we've completed treatment? Well, unfortunately, we know those women will recur. And therefore, there are clinical trials right now that we can offer those women, that we can shine a light on this and say, yes, there is cancer left behind. No, we didn't get it all. And rather than wait for it to be macroscopically evident through tests like CAT scans and bone scans and PET scans, no, instead, if we identify it at its earliest point, our hope is that by catching it early, we'll be able to have a greater impact on eradicating cancer. Now that dovetails perfectly into that second question, which is my cancer coming back? So right now, as a breast cancer surgeon, I do surveillance, which means that I want my patients to come back and see me twice a year for the first few years and yearly thereafter. Well, what am I going to do? I'm going to do a mammogram, and I might do an ultrasound. I might do an MRI. I have very effective tests to look at their breasts and see if cancer has come back. What do the medical oncologists do? What do we do for systemic surveillance? How do we know if cancer has come back elsewhere in the body? Well, as this audience knows, we don't routinely do tests like CAT scans and bone scans and PET scans. We only do that if a woman has symptoms. And that's because we've done extensive studies on this. And what we found is that we're not going to find cancer any sooner just routinely doing PET scans than we would if we just wait till symptoms develop. So the current standard for most women who've had breast cancer for systemic surveillance is simply asking them how they're feeling. Now, circulating tumor DNA testing, this has the opportunity to completely change that dynamic, because what we're saying with ctDNA testing is now we can draw your blood and we can see if the cancer has come back. And if it's come back at this microscopically detectable level. And in fact, the studies that we've done show, we know that as much as 30% of our breast cancer patients will recur. And if we do this blood test, we'll find those recurrences 12 to 18 months earlier than if we simply ask them how they're feeling. So this to me is a revolutionary test, because not only can we identify those who are going to recur much, much sooner, but at the flip side is really what we have to emphasize. And that is, I have a blood test that can tell you that to the best of our knowledge, your cancer hasn't come back. It gives us a dynamic measurement so that the converse is very true, that you can then be reassured that we just did a blood test to look for cancer and how good that can make you feel. You're not going to leave my office feeling like that other shoe is going to fall. So this is a great test. The part that we don't know, though, is if I find evidence of that cancer 12 to 18 months earlier than simply based upon symptoms, is that going to translate into a better outcome? I would like to think so. I'd like to think that there's sometimes a linear relationship. The more cancer that is in your body, the harder it is to eradicate it. But that's probably a simplistic approach. But at the very least, now we have a test that can tell people if cancers come back. And to me, that's very powerful.
What if is there such a thing as a false positive?
False positives with this test are exceedingly rare, exceedingly rare. And so the reality is, and this is not a test for everyone, the reality is that we could be sitting in my office and I could be saying to you, based upon this blood test, your cancer's back. We can't see it. We don't know where it is necessarily. At that point, I'll do a PET scan. And from my limited experience, I've done this under 150 patients since this test has been available. And every single patient where the test has been positive, we've found cancer that's come back. And if it wasn't on the PET scan when we did it immediately, it was on the PET scan 3 months later. So false positives are very rare.
Is the test used for stage 4 patients, Dr. Rosen?
Absolutely. Absolutely. How? It's monitoring response to therapy. So this gives us a way of knowing if the intervention is having an impact. So this can be used dynamically by the medical oncologist to understand if someone is responding to therapy.
And I would share personally that I agree with you. There is no other way, unless we're getting a PET scan, to truly understand if the cancer is really coming back, because I had no symptoms. So some of us don't feel sick when we are walking around with a tumor. So if there's no
and I'm sorry to interrupt, but what we're saying is that PET scan is not effective at finding microscopic disease. So that typically you won't find it any faster on a PET scan than if you do have symptoms. So it's an ineffective means for surveillance. So this test can change that.
So I think for anyone newly diagnosed, how is the test used for the newly diagnosed?
Well, we have a lot of data that's compiled looking at circulating tumor DNA. And what we found is that not every breast cancer patient is going to shed circulating tumor DNA from their cancer into their bloodstream. So I typically will offer this to people who are going to be getting preoperative chemotherapy. So people who are getting neoadjuvant chemotherapy, I'll do ctDNA testing at the time of diagnosis, and then we'll repeat it in the course of their chemotherapy. And then we'll repeat it after surgery. And then we'll repeat it going forward. So we now have a measurement in time of someone's response to the different treatment interventions. So that test is very effective for monitoring someone's response to therapy and for making sure that the cancer hasn't come back. For someone with a very early cancer, the yield is so low, it's probably not necessary. And certainly for someone with pre-cancer, for DCIS, plays no role.
That's a good point. It plays no role.
Correct.
Okay. Is it good for all breast cancer types? Metaplastic, inflammatory, all of them?
Yes, yes. And so even if you haven't had the ctDNA test prior to treatment, so let's say you're 3 years out from your diagnosis and you had stage 2 disease and you just want to be reassured that there's no evidence of cancer coming back, our pathology labs keep our specimens for years. So even if you're 3 years out from your surgery, we can call the lab. They can create that unique signature for your cancer, and then we can do a blood test to see if there is evidence of circulating tumor DNA from your cancer in your bloodstream years later, even though we didn't create the test initially.
And can you explain the baseline of how they use the test? Because from my understanding, they're looking at the initial tumor tissue, is that correct? And then using that as a baseline?
Well, it's not a baseline. They're basically looking at the unique signature of their cancer. So there's certain elements, proteins, different DNA signatures. We're looking at the unique fingerprint, the DNA fingerprint of your cancer. And once we create that unique fingerprint, then we look in your bloodstream to see if that
There's a
cancer DNA is evident. Exactly. So it's not, the test that I create for you is unique to your cancer.
Okay.
And that's why we have such low false positives, because we've created this unique to your cancer.
Can the test pick up any other different cancers? You know,
No.
Okay.
No. We have other ctDNA tests for cancer screening. That's different.
Mm-hmm.
So your audience might have heard of a test called Gallery. Gallery is what we call a MCED test, a multi-cancer early detection test.
Mm-hmm.
Now that is not a unique signature. So we're just looking for any evidence of many different cancers in your bloodstream. That's not a surveillance test, that's a screening test.
Mm-hmm.
Signatera is a surveillance test. Signatera is looking for your unique cancer in your bloodstream.
What about, should it be yearly? How often should people do this test, Dr. Rosen?
Well, it's so early in our experience. I think the simple answer is we don't know. What we've been doing for our neoadjuvant chemotherapy patients is we check it frequently during the chemotherapy. And then after surgery, we'll check it every 3 months for the first 2 years after surgery. And then we'll move to yearly for a certain number of years, at this point, undetermined. But it could theoretically be done forever.
Yeah, because from my work, I understand that hormone receptor positive cancers come back typically after the 5-year mark. So is that correct?
Hormone receptor positive cancers can regrettably come back decades later. So there's never, that's the same reason why when my patients ask me, so when do I no longer have to see you? And I say never, because regrettably, well, even if you're not at risk for a cancer recurrence, most of my patients are also at risk for a second unrelated breast cancer. So surveillance should last forever. But to your point, yes, some cancers, a triple negative breast cancer, if it hasn't come back 8 years later, you probably don't need to be doing a blood test anymore. A HER2 amplified tumor, similarly, after a certain number of years, you may not necessarily have to do the blood test. But for the vast majority of our breast cancers that are estrogen receptor positive and HER2 negative, theoretically, there could be value to doing this test for decades. And it's a blood test. That's all it is. It's just a blood draw. You don't have to go through anything painful.
Yeah.
That's it. Just a simple blood test.
Yeah, they do make it easy. They come to the house. I have a few more questions. So there are some other tests out there that help with detection of reoccurrence, such as maybe mammoprint and things like breast cancer index. How does this compare?
It's apples and oranges. So what those tests are doing is those are not a dynamic test in time. That's a static test. That is also looking at the fingerprint of your cancer. But what it's looking at is it's trying to understand the behavior of your cancer. So we've done many, many studies, and we've correlated the results of those genomic profile tests or molecular profile tests that's interchangeable. We correlate that with how to optimize treatment. So tests like mammoprint and oncotype, they help the medical oncologist decide what's the right recipe to treat that cancer.
I see.
This is a completely different test. This test is saying, is my cancer gone or not? Or has my cancer come back? It's looking for microscopic, indirect evidence of cancer in your bloodstream years after your surgery, theoretically.
Me, as a survivor, I find this to be incredibly cutting edge. I feel fortunate that the advances being made are in the time frame that I am dealing with this as I journey through survivorship. So I just celebrate the fact that
And so true. And the reality is that I think some of my physician colleagues are mistaken when they think that people don't want this information,
Mhm,
because
mhm,
I feel like it's there regardless. I don't I see this in so many of my patients who have gotten chemotherapy, that they finish all their treatment, they're under intense treatment, surgery, chemotherapy, maybe even radiation therapy as well. And then they get to the end. And I think many people at that point are almost waiting for the cancer to come back. And you may be able to block it out, but it's there. And now I have a test that says, no, I've got objective evidence. Cancer's not there. We're looking for the most minuscule amounts. The cancer's not there. Will the cancer be there 3 months later? I don't know. We'll do a blood test again. Chances
mhm,
are it won't.
mhm,
But now you've got a test that will at least give you some evidence
mhm,
more than just hope.
mhm. I
I,
think
I, yeah,
what is being empowered. So I think the key thing here is some people want to know and some people don't. And I think being empowered to know, I have a lot of people who follow me that love the test. It gives them peace of mind. It's something. And so to me, something's better than nothing. But we do have to live our lives either way, whether we're not knowing or whatever. So um, I really appreciate the fact that you're so forward thinking and helping us understand the new advances being made because there is a lot of resistance out there. So,
it, no, it's a wonderful step forward. And my belief, as are many of my colleagues, is that this information is then going to lead to us to provide even more precision care.
mm,
Because this is not uncommon, where we'll give neoadjuvant chemotherapy, and I'll see a patient 3 months into their neoadjuvant chemotherapy, and I'll do an exam and I'll do an ultrasound, and the cancer's gone. And so, what's the inevitable next question that someone wants to say is that, so do I need to finish my chemotherapy? And the answer is yes, because every study we've ever done is based upon getting that prescribed dosage. Well, don't get me wrong, the ctDNA testing today is not going to lower the need for chemotherapy, and that would be a terrible mistake to think so. But we're generating data, and
mhm.
we are doing the studies right now to answer that question. And I think in the next 2 to 4 years, we are going to be able to answer that question, that yes, if you clear the ctDNA from your bloodstream of your cancer really quickly after getting one type of chemotherapy, we probably don't have to give you the other type of chemotherapy. That to me is the
Wow.
precision care that we need.
Yeah.
That's the future. It's not the present, but I do believe it's the future.
Well, I can't thank you enough, Dr. Rosen. Could you say something about this particular page that we're working on together? Just a small thought or just your closing thoughts?
Well, that it's a great resource, because this is not simple.
Yeah.
It, I don't expect the audience to have a degree in biology or molecular biology.
Right.
And I think this breaks this down so that you can understand in simple layman's terms what this test does and what it doesn't do, and
Mhm.
whether this test is right for me. But ultimately, hopefully, each and every one of your patients who are listening has the go-to expert that they can turn to.
Sure.
And if your doctor feels that you're a candidate for ctDNA testing, then this might be a perfect test for you to get. If you think you're a good candidate for ctDNA testing and your doctor doesn't, get a second opinion.
What I did. I mean, I did exactly that. I wanted it. So I found the second opinion. So It's definitely new, everyone, and it's just grateful to have Dr. Rosen be able to share just the advances and break it down for us, because this is a lot to process. So thank you so much, Dr. Rosen. And this page is for everyone to really digest it and ask questions and be empowered.
My pleasure.